Now let's take another look at the guidelines of the European Society for Vascular Surgery. And it's basically the same for patients with lower limb superficial vein thrombosis. Ablation of the incompetent superficial veins should be considered once the acute inflammatory and post-thrombotic phase has subsided, at least 3 months after the most recent event. And if you look at the evidence, that's class 2A, level of evidence C, so that's little evidence. Basically, it's a consensus opinion. But in both guidelines of the American Venous Forum and the European Society, the recommendation is to wait until the inflammation settles. So for the 3 examples that I've just given, the distal great saphenous vein thrombosis, the proximal great saphenous vein thrombosis that's not reaching up to a saphenofemoral junction, and for the extensive extensive superficial vein thrombosis reaching up to the saphenofemoral junction, for the 3 examples, the recommendation is to wait until the inflammation settles, according to the European, 3 months, and then to do the definitive great saphenous vein ablation. Now I'm going to present a not case that goes a little bit outside all the guidelines. So that's a 52-year-old female patient who presented with 2 days of shortness of breath, quite significant shortness of breath. She had thrombosed varicose veins, as you can see, thrombosed varicose veins in the left leg, and thrombosed distal great saphenous vein. She had no other relevant history. She was obviously tachypneic and tachycardic. And this is her duplex scan, which shows a thrombosis of the great saphenous vein in the distal leg. But if you look at the proximal 2/3 of the thigh, the saphenous vein was actually patent, of 5.6 millimeters in diameter and showing severe reflux. So the working diagnosis of this lady that she had superficial vein thrombosis complicated by pulmonary embolism. She had the laboratory investigations. Her hematology and chemistry profiles were within normal. So CT chest, which showed no abnormality. The CTA chest showed multiple small peripheral pulmonary emboli. Her CT abdomen pelvis showed no malignancy. Her echo, she had non-significant pulmonary hypertension and no right-sided train. So she was treated with therapeutic full-dose anticoagulation. Despite the treatment with therapeutic anticoagulation, this lady continued to deteriorate. Her shortness of breath became worse. She had worsening hypoxia. She was actually admitted to hospital, and she continued to have full-dose anticoagulation. Now, this lady has recurrent pulmonary emboli despite adequate anticoagulation. What would you do? Here are the options. Continue anticoagulation, which she was already having, thrombolytic therapy, IVC filter. Why think about filter? Because continuous recurrent pulmonary emboli despite anticoagulation is one of the indications of IVC filter. Ligate the saphenofemoral junction to stop the emboli. Great saphenous vein stripping, maybe. Or great saphenous vein ablation. Can I stop here and ask the discussant to give their opinion? We can't hear you. Dr. Kabnick,
Rashad, I'm going to take over here because I think we could spend an hour on this conversation here, but I wanted to start off really basic. And I wanted to go to the discussants to talk about guidelines, consensus, and then if we have time at the end, we'll give what our opinions are for this case. But I want to start with Erika Mendoza. What do you think about the guidelines? I'm giving you a little bit of history. Back in our day, we did immediate ligation of the saphenofemoral trunk, and through studies, we found that that probably was not helpful and caused more harm. So I leave the floor to you.
It is interesting because I was part of an international trial over Vascular. I think it was in 2005. because in Germany they claimed very much to do still this immediate crossectomy and stripping. And Professor Hach published cases of embolization during the stripping, because invagination the vein, there were thrombi going through the perforating veins. And we found out, you made an international evaluation of answers, and it was completely despair. Everybody did what he was taught, and nobody had a real answer. And it is like you said, Rashid, in the presentation, thank you, because it's very, very clear until now that there is no evidence to make a real guideline or a real recommendation, but it seems like immediate crossectomy when the thrombus is in the region of the saphenofemoral junction is too harmful. This is my comment to the guidelines.
You're on mute. Kabnick, you're mute.
I know I am, but I'm not mute. I'm never mute. You may not hear me, but I'm not mute. So the idea is, do you have any questions before I turn it over to Ravul?
Yes, I would offer one more possibility in the options, and this would be to do a coagulation test, because she's on DOAC and she could have a lupus anticoagulation problem. You know, this is what I would add.
Yeah, she had this.
There are several. I'm sorry. There are several things that we could talk about. So I'm going to weigh that case and leave it alone. Ravul?
Yeah, thank you. And a very nice presentation, Rashad. Coming to questions by Lowell, like upon the guidelines, you know, we get a lot of patients on SVT in our setup because patients present quite late. I think there are two important things. One is to differentiate SVT in a varicose veins and SVT in a normal vein. I think that's a very big difference when you treat clinically. And I think in looking into the guidelines also, we need to look into it, because we all know that, you know, the clinical practice, when you have a clot in the varicose veins patient, it behaves much milder. But when you have a clot in the non-varicose vein patient, you need to look into that this patient they're normally young patients. Does this patient has malignancies? Does this patient has got hypercoagulable state? Because you're not going to investigate thoroughly like this if you have a clot in the patient with varicose veins. I think that is one we should be very clear to differentiate what we are talking when we talk about SVT. Is an SVT in varicose veins, or it's a non-varicose vein SVT? You know, that's one very basic difference. I think as a clinician, we need to look into it. So coming to, let's say, varicose vein patients, I feel putting in the guideline, I don't like this fondaparinux for 6 weeks. You know, there is no reason why we should be giving and injecting a patient for 6 weeks of fondaparinux, because then you can do it with NOACs. And I think that is one very important thing. I think we should put these patients on only, I think the newer guidelines, we should be putting these patients on NOACs from the first day. And all these patients, they respond very well. I think that's one very important thing. And they only included rivaroxaban, not the, you know, the other drug, and Eliquis. And so that's the apixaban was not included. And so we have used in more than 100 patients in apixaban also. And I think that's another thing we should include in the newer guidelines. Another DOACs can also be used, not only rivaroxaban. You know, I think that's one very important factor I think we should include into the newer guidelines. Coming to the last question, you know, should we do it early or late? I think delaying for 3 months, absolutely, I don't agree with that. You know, I started doing like 15 years back at 4 weeks. And the reason for that was because, you know, when you are going to operate at 3 months, will you give a prophylactic anticoagulation into this patient when you do a laser or not? You know, that's another very important question to ask. If yes, because this patient had a previous SVT, then you're going to give another 2 weeks of anticoagulation unnecessarily to these patients. So I started doing at 4 weeks, 11 years back, and we did not had a single episode of recurrent DVT or a pulmonary embolism, and we're very happy. From last 1 year, I thought, why do we should wait for 4 weeks also? Why can't we start doing it 1 week? because most of the pain and the inflammation settles down in 7 to 10 days. So we have done like 34 patients now, and we, after 10 days of intervention, and every patient responded very well. Patient settled down much faster, and and we continue the anticoagulation up to 6 weeks. So I think in the future, it will be that you give an anticoagulation, wait for 2 weeks or 3 weeks, do a surgery, continue the anticoagulation for 6 weeks, prophylactic, and so the patient gets free earlier.
Thank you, Ravul. It sounds like Ravul Jindal's experience, and that's great. We could argue with you day in and day out in your experience, because we have ideas about inflammatory states. We have ideas that continuation of an inflammatory state means you're at a higher risk for DVT. If you are to do an ablation if you're tying off the junction, we already know what that problem is. So I'm not sure that there's a difference. But I'd like to go to Rashad's example of a very difficult case. And then if we have time, we can go back and look at Ravul and what he said. First of all, there are things that we need to know, Rashad, about this patient. And it seems like the patient has significant right heart strain. And we wanted to know what the echo showed. And that's one question. And number two, if there was significant right heart strain, we need to classify these PEs as being severe, moderate. And then the question is, do we approach those first? How do we approach this? So I need a little bit more information from you. I think the treatment of the saphenous junction is, to me, important, but not as important as trying to help the patient with the pulmonary embolism. So the floor is yours.
Yeah, thank you for the question. Actually, the echo did not show right heart strain, so it's not moderate and it's not severe pulmonary emboli. It's kind of mild pulmonary emboli. She had non-significant pulmonary hypertension and no right-sided dilatation. So it's not a severe pulmonary embolism.
Thank you.
That's where it stands. And regarding Erika's question, yes, she tested positive. She's factor V Leiden positive, and she was heterozygous.
May I?
Please.
Yes, but this is a very little thrombophilia. If it is heterozygote for factor V, it is like being I am blood group A and you perhaps 0, and the risk for me having thrombosis against you is the same than factor V heterozygote or not. The question was if she has a lupus anticoagulans complex, because this one would avoid the DOACs to work. You know?
Yeah, no, she doesn't. Yeah.
It's okay.
No.
Thank you.
So, Ravul, before we go into what you would do.
Yeah. Rashad, what was the weight of the patient, and what anticoagulation was being given to this patient?
Yeah, she's average weight, like 70 kilos something. And what anticoagulation? She was placed on enoxaparin, which in our side of the world is called Clexane, and that's 80 milligrams twice daily.
Okay. And once you see that this patient had a repeated anticoagulation, did you added an ecosprin to it, antiplatelets?
Sorry, what did you say about antiplatelets?
So if you have seen this patient having a repeated emboli, did you added an antiplatelets to it?
No, we did not add an antiplatelet. We admitted her to hospital to make sure she's getting the anticoagulation properly in full dose and to monitor her hypoxia. Her hypoxia was getting a little worse. She's definitely was not getting better. She was short of breath, and we thought we had to do something.
Rashad, before you go on, Ravul, what evidence do you have with an antiplatelet drug in this situation?
No, I actually don't. I don't have an evidence like a publication. These are rare cases where even if you are on a full dose of
What evidence
enoxaparin.
do you have with antiplatelets and DVT?
Yeah, so what we have seen is that these are rare patients who, even on full dose of anticoagulations, still have an repeated episodes of an pulmonary embolism. And what we found was that you see 1 or 2 cases every year, and what we found was that if you add antiplatelets to these patients, most of these patients, they responded having a repeated emboli, because you don't have any other choices, because if the patient is already on full anticoagulation, and that also low molecular heparins, and then
this is anecdotal, right?
yes, absolutely.
So you need to start to collect. I mean, you've got a plethora of data and information. You need to start getting that out so that we can start to look at that. So
Absolutely.
this patient had significant respiratory distress related to showering of pulmonary emboli is what it sounds like. So Erika, what would you do?
I would, if I remember the case correctly, the proximal GSV was free and with reflux, and I would do something, either crossectomy or a proximal ablation, in introducing the device proximal to the proximal end of the thrombus and close the way out of the great saphenous vein. But if I saw your picture correctly, I think she had also a thrombus through the perforating vein. Is that, they do not embolize as often, but I would first of all close the saphenous vein junction.
Ravul.
I think the first thing is it's a very, very rare thing, an SVT on full dose of anticoagulation, still having an embolism. I have never come across such a case. And DVT, yes, but not an SVT having a repeated. So first of all, need to look into it, that what are we dealing with? Is it such a severe thrombogenic patient that is causing an embolic phenomena, or because
What would you do, Ravul?
Because depending upon that, what I found, because ligation
This is
maybe
a
one.
patient that's tachypnic in distress, having multiple pulmonary emboli.
Then I put in a filter.
Okay, so failure of treatment. What else would you do?
Failure of treatment. Failure of treatment and ligation of SFTA, already told by Erika, but that's more than enough.
Would you ablate? Would you ablate the saphenous vein that is peripheral to the SFJ, or just ligate? Yes. Okay.
Ligate the SFJ and put in a filter, anticoagulation, and I will add double antiplatelets to it.
Well, I agree with you, except for I don't think there's any harm in platelets, but I don't have very much evidence. But I agree with the failure of treatment on anticoagulation and the necessity of protecting this patient with a temporary filter as well as ablating. Rashad, what did you do?
Well, we did exactly like what Erika said. We ablated the patent refluxing saphenous vein that is proximal to a thrombosis. And amazingly, the patient recovered the next day. So the next day, the shortness of breath was so much better. Hypoxia was so much better. And that's it, really. We kept her on anticoagulation for 3 months. And I followed up the patient, and all was good. Okay, would you allow me to share one more slide, please?
Please.
So we went on, ablated the great saphenous vein. This case was actually published in year 2014 in the European Journal of Vascular and Endovascular Surgery. Now we are 12 years following this case, and I've never seen another case like this. So it's like Ravul said, it's rare and it's odd. And I would like the message out of this symposium to be clear: when to ablate the refluxing great saphenous vein following SVT. Well, according to the European consensus, at least 3 months after the most recent traumatic event, and that's what I would do. But I think we can we can argue with this we could say Ravul is saying 2 weeks. I'm not sure what Erika says. I'm not sure what you do, Dr. Kabnick.
Well, for me, it's to decrease the inflammatory response, and that's why 3 months is up there. But again, there's not a whole lot of evidence to support that other than a group of physicians that are in agreement. And I'm looking for evidence in terms of that. So typically inflammation can last between 6 and 3 months, and I am a little bit more aggressive than 3 months, but longer than 6 weeks. So I don't have a real recommendation at this point, but it's interesting that this patient had multiple showers of emboli, and just a ligation seemed to help this patient. So it's kind of interesting that we looked at, Ravul and I did, with filters, and I'm not, if they were minor, I mean, if they were miniature pulmonary emboli, which they usually are like that, I'm not sure we would have helped the patient with a filter, but we would have helped that patient with a ligation or an ablation at that. And I think that was tremendous. And thank you for that case. That was a good case. Any final words?
Yes, I would like to answer the question also. I was part of this Callisto trial, and there are more trials demonstrating that really fondaparinux is better than all the other injectable medication for superficial vein thrombosis. It is quicker in the recovery, and the length was titrated because the 6 weeks was the moment where the recurrence rate was less. So if you treated 6 weeks, for example, for a peripheric thrombus, the recurrence rate was less. But my way to do is I put them 6 weeks on anticoagulation, and I use fondaparinux.
Hurry up, please.
Yes, and I see them at 4 weeks because you should keep them on anticoagulation until you operate.
Thank you.
It is.
Well, thank you, Erika. Appreciate it. Rashad, last moment, and then I've got to introduce next week. So quickly, anything else?
Well, no, thank you very much. That's what's very,
I'd like to
very
thank
exciting.
everybody. I'd like to thank everybody for their time. We try to keep on time. Next week, we're going to be talking about why venous leg ulcers have difficulty healing. And that will be led by Dr. Eric Hager, who's a speaker, and then Thomas Wakefield and Thomas O'Donnell will be the discussants. So it should be really interesting. So we'd like to thank again all of them, and we'll see you again next week. Thank you very much.
Thank you. Thank you. Bye-bye.
Thank you.
Bye-bye. Bye. Bye.